Thank you. I would like to thank the organizing committee, and I must say that I am fascinated by the program, by the Thoracic program. It's a wonderful program. But I understand that there are not so many surgeons who want to push the borders of thoracic surgery. And here's another chapter, which is surgery for pulmonary sepsis. It's a non-evidence-based approach. Every one of us see once or twice in a year that we could not collect data. Different surgical techniques are employed. Terminology is really complicated. Acute necrotizing pneumonia, gangrene, and abscess, and also acute infectious pulmonary destruction could be used as terminological names, and clinical conditions varies from patients to patients. And community-acquired and hospital-acquired types of pulmonary sepsis may change, and I want to particularly concentrate on the life-saving surgery on acute necrotizing pneumonia, lung gangrene, and lung abscess. We also have complicated infections which coincide with the lung cancer and cavitary lesions like cyst hydatid or Wegener. And we have uncommon conditions for pulmonary sepsis like tracheoesophageal fistula and bronchobiliary fistulas, and also postoperative problems as necrotizing pneumonia. But in general, we can say that acute infectious pulmonary destruction could be named as a form of parenchymal destruction and serious fatal complications of the pneumonia. We have some equipments to do something to those patients before fatal things occurs. We may suck with the thin catheters through the bronchus with a bronchoscope, and or do a percutaneous transthoracic drainage to those patients. And if pneumothorax develops, that's one of the urgent situation. Temporary bronchial occlusion and drainage of the pleural cavity may be needed to prevent the aspiration to the contralateral lung, to prevent the soiling of the infection on the healthy side of the lung. And the bronchial occlusion is indicated, and it should not stay longer than 30 days, when drainage is not effective, and no signs of lung expansion, signs of aspiration of pus and contamination of the clear fields of the lung, and massive air leak, presence of massive air leak. There are some findings which demonstrates us the unfavorable prognosis. These are continuous fever and chills, sweating, poor performance status or other intoxication signs, high amount of sputum, gradual deterioration, long-standing advanced lung infiltration, progressive anemia, hypoproteinemia, and electrolyte imbalance, and development of other complications like massive air leakage or hemoptysis. And clinical indications of surgery are failed non-operative management despite interventional endoscopy and radiology. And these include clinical deterioration, persistent air leak and respiratory failure, advanced pleural emphysema, pulmonary sepsis, septic organ failure, hyperdynamic septic shock, and major hemoptysis. Surgery for such infectious septic diseases varies from patient to patient. It changes among cavity debridement to pneumonectomy. Cavity debridement, abscessoscopy, wedge resections, Monaldi cavitary drainage, and all types of anatomic resections could be employed to those patients. And there are also some specific procedures for pulmonary sepsis who have tracheoesophageal fistula. You know, basically we diverse the esophagus, we perform feeding jejunostomy, aspiration gastrostomy, and ligation of distal esophagus and a pharyngostoma to prevent soiling to the trachea, and treat these patients after all lung feeds are clear and patient has been separated from the mechanical ventilation. And Bronchobiliary fistula is another major complication causing septic shock. Is also a dangerous situation. In that situation, you shouldn't go immediately to lung and resect and to lung and divide the fistula. First of all, you should decrease the tension in the bladder, gallbladder system, in the bile system. That could be performed by placing a stent to the ductus, bile duct, or external drainage. And after this decrease in the pressure of the bile in the liver, then you may go for the correction of this fistula, which is present between the liver and the lung. That's an extremely rare surgery. I'm not an expert in that field, but I see quite a few patients in each year, and I'm sure many of you see similar amount of patients like I do. And surgery, the problem is surgery is fatal and really complicated because of the hemodynamic instability, septic physiology, extent of lung injury, magnitude of intervention required, and residual problems, residual space problems which are present or which may be anticipated. Radiological indications for surgery are not well established as in soft tissue infections, but empyema, bronchopleural fistula, acute necrotizing pneumonia, lung gangrene, and lung abscesses could be diagnosed from the chest CTs. On the left side, you see acute necrotizing pneumonia. It's a consultation with peripheral necrosis and multiple small cavities, patchy inflammation with micro abscesses, and the most important part is this lack of perfusion. In acute necrotizing pneumonia, you must have a CT with contrast, and you don't see perfusion in the infected area, infected zone, infected lobe. In lung gangrene, it shows consolidation with patchy perfusion in the lower lobe surrounding a large cavitary lesion. And again, in the left upper side, you see a necrotizing pneumonia, acute necrotizing pneumonia with patchy area of necrosis without perfusion. On the right side, in the upper part, you see acute necrotizing pneumonia with combination of lung abscess. And in the lower left side, you see empyema, acute necrotizing pneumonia, and lung abscess. And on the right side, you see a pulmonary gangrene, a consolidation followed by extensive necrosis of the lung, which shows cavitations and lack of perfusion. In some papers with small number of patients, there are chest CTs which shows the bronchial fistula after acute necrotizing pneumonia, or hydropneumothorax, which is a complication of, again, an acute necrotizing pneumonia and lung gangrene. And again, on the left side, you see HIV-positive patient with the distracted lung because of lung gangrene. And on the right side, you see ARDS-like chest CT, which started ARDS-like chest CT and changed into acute necrotizing pneumonia, and you can notice the abscesses located in the lung field, small abscesses. This is one of our patients who was operated on recently by our cardiac surgeons. He's a young, let's say, 16-year-old tetralogy of followed patient who was corrected completely, and after the total correction, the patient developed gangrene of the right upper lobe, and the surgeon did not recognize the previous chest CTs, which come back later, which demonstrate pulmonary venous return anomaly. You see the right upper lobe vein is returning to the left innominate vein. We revised the patient and divided this vessel and reanastomosed it to left atrium, but it did not work. The lung still needed to be resected, but we lost this patient. The aim of lung resection is to remove the primary source of ongoing infection, remove all necrotic lung tissue and debris, and preserve the surrounding healthy lung tissue and take preventive measures for the complications. For the treatment of lung gangrene, for the surgical treatment of lung gangrene, surgery is recommended almost in all of the cases. And in acute necrotizing pneumonia, percutaneous drainage is not recommended due to higher failure rate and complications. And surgical outcomes are related to the extent of the disease and extent of the resection and overall condition of the patient. And mortality rate varies from change between 40% to 15% in different series, but also this paper claims that in diffuse forms, mortality rate is around 40%. In critically ill patients, drainage of empyema could be done, and interval lung resection can be planned when patient is stabilized, but to tell the truth, this interval period may never come, and you must act very carefully during these periods. And in majority of the resections, lobectomy or pneumonectomy are required, and stump support is a must in these type of surgeries. Another report which was recently published, it was published in 2014, studies on emergent pneumonectomy for lung gangrene, and does the outcome warrant the procedure. 26 lobectomy patients are compared with the 11 pneumonectomy patients in terms of age and Charlson comorbidity index and combination of them, and no significant difference in postoperative mortality was noticed in between two groups. So pneumonectomy could be an option in the treatment of acute necrotizing pneumonia and lung gangrene. If we look at the other series, we can see that procedures include lobectomy, pneumonectomy, and limited resections. The stumps are always secured with healthy tissues, and the postoperative deaths are due to septic shock and multi-organ failure, and the mortality rate is around 14%, which can be acceptable in such a mortal situations. In another study, it was demonstrated again that resection could include cavitary debridement, large wedge resections, bisegmentectomies, lobectomies, pneumonectomies, and the deaths occurred again due to the septic conditions and due to organ failures, and the mortality rate is around 20%. And postoperative empyema is another sign of the mortality, and especially it occurred in patients who did not have an irrigation system placed perioperatively. In another series, acute necrotizing pneumonia constitutes most of the patients. The remaining are lung abscess, lung gangrene, and necrotizing tuberculous granuloma. And only one patient died in this series due to comorbidities, and the resections were pneumonectomy, which were right-sided, and 3 of them are right-sided, lobectomy, mostly right and left lower lobes, and segmentectomy, wedge resections, and debridement. Latissimus muscle flaps are used to buttress the bronchial stump or to fill the space after the resection, anticipated space after the resection. Again, another study which shows the margin of the resections from debridement to pneumonectomy. Interestingly, this paper claims that serial CT evaluation every 2 days or every 3 days shows the potential behavior of the disease. CT scans can predict likelihood of failure of medical therapy, and surgical candidates are those who have persistent sign of infection, if lucky, without any vasopressors. Poor prognosis could be identified by having diffuse bilateral parenchymal inflammation and ventilator dependency. And ventilated patients can still be appropriate candidates for resection if there is continued evidence that the parenchymal necrotizing process is likely the source of the persistent sepsis. VATS resection could be performed in some patients, and in some series pneumonectomy is avoided, and in those series mortality, you may not notice any mortality in among these patients. And generally, this series is a nice example of this. Admission to initial surgical consultation takes 1 to 6 weeks, average 2 weeks to see such a patient. Debridement of the lung could be considered in pediatric cases, and that's almost always done in critically ill acute necrotizing pneumonia patients in the infantile period by the pediatric surgeons. They prefer debridement more than the anatomical resections. Postoperative period in those patients are really complicated. This constitutes ECMO, hemofiltration, and tamponade of pleural cavity with towels to stop hemorrhage, and revision several days later, or open window thoracostomies. And as a conclusion, acute necrotizing pneumonia and lung gangrene, surgical resection is recommended in acute necrotizing pneumonia and lung gangrene when there is no response to medical treatment. The failure of medical treatments is evidenced by persistence of sepsis and development of complications. The aim of the surgery is to remove all septic foci to improve the prognosis, and preventive measures for bronchopleural fistula and emphysema should be taken. For lung abscess, it's not the same as described before. The treatment to lung abscess include internal drainage, percutaneous catheter drainage, closed tube thoracostomy drainage, pneumonostomy, and very rarely resectional surgery after the development of complications, which are bronchopleural fistula, emphysema, pneumothorax, and bleeding. And there are some other cavitary lesions which may develop after pneumonia or pneumonia-related ARDS, multiple lung sepsis, and hemodynamic instability, ventilation pressures, PA pressures, prognosis, and cultures are important in treating these patients. And also some other disease may have septic lung disease due to infection of the cavity with a complicated microorganism. And here is an example of a patient who developed pneumonia and ARDS and septic shock, and was noticed to have 2 abscesses in the both lung fields. We placed bilateral Monaldi drainage, and the patient weaned from mechanical ventilator in 15 days and removed them later. Another example is a wheat aspiration, and this wheat located in the lower lobe, and a persistent pneumonia and sepsis and lung abscess developed. The resection was unavoidable in this situation, and the lower lobectomy was the reason for the resection. Another mental retarded 18-year-old female with a carcinoid tumor at the origin of the left main bronchus, and he had a distracted lower lobe and the continuous septic disease of the lung, and had a resection of the segmental resection of the main bronchus and the left lower lobectomy, who went very well and discharged in 7 days. And some patients developed septic findings due to coexistent diseases like multiple myeloma or underlying cancer. Here's an example. We thought very carefully about having a resection. At last we decided to resect this patient. And another septic condition may occur after perforation of hydathic cyst, and these patients may require debridement at least, but may also require anatomical resections due to involvement of the lung. For those who could not be treated with endobronchial or percutaneous way, the abscess, anatomical segmentectomy could be a good option if it's in a good location. It's in a available location for the segmentectomy operation. I mentioned about the bronchobiliary fistula and stabilization of the fistula, and the resection of the liver, part of the liver, diaphragm, and lobectomy, and then in the same settings. Actually, it should be done in the same setting, and the reconstruction should be done very carefully, as well as drainages. And trauma may be a reason of lung gangrene. Here you see a patient who had a bronchial rupture and who was treated with in another center with some sutures, and after re-evaluation of the patient, sleeve resection of the right upper lobe bronchus and the upper lobe became the mainstay in treatment of this patient. And another patient who had a large wedge resection, which occluded the pulmonary vein, underwent gangrene and underwent left lower lobectomy for the septic conditions. As a last slide, I want to draw your attention on AMP and lung gangrene mainly. These lesions are difficult to differentiate from other pneumonia and lung abscess. If you differentiate these lesions from a perfusion, from the lack of perfusion in the lobe, from the abscess formation, from the cavitary lesions, or from the complications of this disease, please consider surgery as early as you can before the patient deteriorates, before the patient is intubated. If the patient is intubated, there is a vague area to give a decision. You may treat the complication first and wait for a recovery of the patient, if he can. I'm not sure he will, and then you may reconsider surgery in those patients. And the timing of the surgery, a refined technique, and taking preventive measures and being ready to complications are the key measures of this operation. And for lung abscess, if you are sure that the patient has a lung abscess without necrotizing pneumonia and gangrene, you may consider to have non-operative and minimally invasive approaches like suction from the bronchial side or suction from the thoracic side. Thank you for your attention.